Bismillah ar-Rahman ar-Rahim. Retinopathy of prematurity. What is retinopathy of prematurity? It is a form of proliferative retinopathy that affects premature low birth weight babies, often but not necessarily exposed to high ambient oxygen concentration. To understand its pathogenesis, it is important to know the normal retinal vascularization. No blood vessels are found in the retina till the 4th month of gestation. The nasal periphery is completely vascularized at the 8th month of gestation, while the temporal periphery remains unvascularized till about 1 month after gestation. The avascular retina produces VEGF in utero. VEGF stimulates vascular migration in the developing retina. The increased metabolic demand of the growing eye leads to excessive VEGF production. In premature birth, VEGF production is downregulated and vessel migration is halted. This leads to the vascular proliferation seen in retinopathy of prematurity. A more in-depth explanation, we have many types of growth factors. Some of them are oxygen regulated and others are non-oxygen regulated. The oxygen regulated include vascular endothelial growth factors and erythropoietin. The non-oxygen regulated include insulin-like growth factor 1 and omega-3 polyunsaturated fatty acid. In utero, the new vessel growth are stimulated by the vascular endothelial growth factors. If premature birth occur, the vascular endothelial growth factor will be down-regulated together with other growth factors. Increasing metabolic demand and hypoxia will result in a reflex increase in most of these growth factors, which will result in secondary retinal neovascularization. If you catch this stage and decrease the VEGF production by anti-VEGF, which is early treatment, you will have resolution of retinopathy, while in late treatment after this complication will suppress the normal level of VEGF and result in vascular complications. How can we detect active disease? To know active disease, we need to know many terms, which are the zones of disease, extent of the disease, stages of the disease. We have 3 concentric zones in retinopathy of prematurity. The first and most important one is the central one. It is a circle concentric with a disc, which means that its center is the optic disc and its diameter is twice the distance between the optic disc and fovea. This is the circle, zone 1. It is concentric on the disc and its diameter is twice the distance between the disc and the fovea. The second zone is another ring concentric with the first one until it reaches the nasal periphery and its diameter, there is no mentioned diameter, but it should reach the nasal periphery. The third zone is the residual temporal crescent. Extent is determined by clock hour. We can divide the retina into 12 clock hours like a clock. Each one of them is 30 degrees. Staging. 5 stages are used to describe the abnormal vascular response. This response occurs at the junction of the immature avascular peripheral retina and the neovascularized posterior retina. We could have more than one stage at the same eye. For example, stage 1 in some place and stage 2 in another. Stage 1 means demarcation line, which is a thin, flat, tortuous gray line, like this one. It runs roughly parallel with ora serrata, mostly temporally. How can we see it? We will follow the blood vessels, which are abnormal branching vessels. It will lead us to it. Stage 2, ridge. At the site of demarcation line, it has height and width, and it is elevated above the plane of the retina. The blood vessels enter into the ridge. Small isolated neovascular tufts, which are called popcorn, may be seen posterior to it. By posterior means towards the posterior pole. The ridge is the line growing up. As the ridge grows, it will result in extraretinal fibrovascular proliferation, which extends from the ridge into the vitreous. It is continuous with the posterior aspect of the ridge. The highest incidence of this stage is around the post-conceptual age of 35. Stage 4, it means partial retinal detachment. We divide it into two stages, A and B. A, extrafoveal, which is a better stage because the fovea is not involved, and stage 4, which involves the fovea. The detachment is usually concave, as there is no break in the retina, so it usually takes a concave appearance and is circumferentially oriented. Progressive fibrous contraction causes the detachment to extend both anteriorly and posteriorly till ending into total retinal detachment. Plus disease. This term is used to signify an active disease and is usually progressive disease. Many factors contribute to the term of plus disease. These include failure of the pupil to dilate associated with gross vascular engorgement of the iris, vitreous haze, increasing retinal and vitreous hemorrhage, dilatation of the veins and tursosity of the arteries involving at least two quadrants. So any one of this, we will add the term plus. When to treat, previously we rely on the term of threshold disease, which are 5 contiguous or 8 cumulative clock hours. Stage 3, which is extraretinal fibrovascular proliferation, zone 1 or 2, and associated with plus disease. Nowadays, we rely on the early treatment retinopathy of prematurity group, which are in type 1 disease and type 2 disease. Type 1 disease means a high-risk disease which needs treatment. They include any ROP stage in zone 1, accompanied with plus disease. Stage 3 to any extent within zone 1, stage 2 or 3 in zone 2 together with plus disease. However, patient needs follow-up only in type 2, which is stage 1 or 2 in zone 1 without plus disease, stage 3 ROP within zone 2 without plus disease. In some patients, we encounter cicatricial complications. They are about 20% of cases with active ROP. It varies from innocuous to very severe complication. It also passes through 5 stages. The more posterior the disease at the time of presentation, the more severe the cicatricial complication. They include stage 1, peripheral retinal pigmentary changes with haze at the vitreous base. Stage 2, temporal vitreoretinal fibrosis and the dragging of the temporal arcades, followed by dragging of the fovea and the disc, resulting in pseudo-exit-work. Stage 3, more peripheral fibrosis with contracture and falciform retinal folds. Stage 4, incomplete ring of retrolental fibrovascular tissue with partial retinal detachment. Stage 5, complete ring of retrolental fibrovascular tissue with total retinal detachment. Both these stages can present with leukocoria in neglected children. Regression. Fortunately, it occurs spontaneously in about 80%. Either by involution or changes of fibrovascular tissue. It may even occur in eyes with partial retinal detachment. Why we should follow up these patients? Because the incidence of myopia and strabism. Screening. Who? Those born at or before 31st week of gestational life, weighing 1,500 grams or less. How? The best is wide field retinal camera. If it is not accessible, use 22 or 20 diopter lens, band-fundoscopic Volk lens. When? 4 to 7 weeks of postnatal life to detect the onset of threshold disease or active disease. Then at 1 to 2 weeks of interval up until the retinal vascularization reaches zone 3, which is the temporal periphery. How many children or infants need treatment? Only 8% of screened babies will need treatment. This is a picture of RetCam used for screening of retinopathy of prematurity. Treatment. If the patient needs treatment and only laser is available, peripheral retinal ablation will do. Nowadays, most of treatment line depends on intravitreal injection of anti-VEGF, whether bevacizumab or ranibizumab or other recent anti-VEGF. Lens-sparing pars plana vitrectomy is available for stage 4A with good visual records in contrast to stage 4B or 5 where the fovea is decreased. Peripheral retinal ablation with laser photocoagulation is an efficient line of therapy. The laser is applied to the avascular immature retina. Successful in 85% of cases, the remainder progress to retinal detachment. Laser photocoagulation has replaced cryotherapy largely due to better anatomic and visual outcomes and because laser induces less myopia. We apply laser therapy either confluent or one burn width apart until we cover completely the avascular peripheral. Anti-VEGF block retinal neovascularization. They are used widely nowadays as a first line of treatment. Optimal timing and frequency are not established yet. The potential for systemic complication and long-term effects are not established yet also. Pictures taken with RedCam. You can see here the peripheral vascular abnormalities leading to a ridge, to a demarcation line. Again, peripheral vascular abnormalities seen superiorly. Peripheral vascular abnormalities seen superiorly. This is a ridge of follow-up after treatment with Lucentis, nearly complete vascular regression of the avascular abnormalities with restoration pattern. Thank you.